Good evening to the esteemed faculty, respected consultants, and all my postgraduate students. I am Dr. Asmita Patil, Senior Resident from Department of Anesthesia and Critical Care. I'm working in Valavalkar Medical College in Ratnagiri, Maharashtra. It's my pleasure to welcome you all into today's ISA National PG online class. The conduct of pediatric anesthesia presents many challenges. Due to their unique physiological and developmental characteristics, administration of anesthesia becomes more intricate for pediatric patients. Our today's topics include case discussion for upper respiratory tract infection in pediatric anesthesia and anesthetic considerations in tracheoesophageal fistula. Our sessions with esteemed faculty and well-prepared presenters will ensure thorough discussion that will help the postgraduate students to deal with the challenges. Before we begin the class, let's invoke the blessings of Ma Saraswati with the blessings with this Saraswati Vandana. May I now request our Honorary Secretary, IC National, Dr. Sukhminder Bajwa sir, to address the audience.
Thank you, Dr. Asmita. Today's topics actually are very, very good topics because right from our post-graduation days, when we encountered these cases, so we were extra excited to get these cases done, to learn from these things, how to give administer in anesthesia to these cases. That as the principle goes, the pediatrics are not the young adults, so all the physiological, the anesthetic, and even anatomical variations are there in the pediatric patients. So it's always difficult. I think everybody who goes to get these cases done in the morning, in the routine, or even in the emergency OT, even pediatric cases are encountered. So you get extra vigilant about everything. And that's why this specialty is now increasing to a different standard, with the pediatric anesthesia as a different entity now. So I think we have better teachers today because they are regularly doing those PG assemblies and pediatric anesthesia. I think they're doing in a very fine manner. So it is my privilege that to have a class from them. So Smita, kindly introduce all the esteemed members for today's presentation.
Thank you for your inspiring words, sir. Now I would like to introduce our moderators, esteemed faculty for today's sessions. So, our first faculty is Dr. Mamta Harjai ma'am, professor in Department of Anesthesia and Critical Care in Ram Manohar Lohia Institute Medical Sciences in Lucknow. She has a PG teaching experience for 17 years. She has a specialty interest in airway, pediatric, obstetric anesthesia, as well as ultrasound guided blocks and critical care. She is a holder of certificate in BLS and ACLS instructor, pediatric trauma care instructor. She has 25 index publications in 3 chapters, reviewer of many indexed journals, and she is an executive member of Indian Association of Pediatric Anesthesia in Lucknow City branch, with holding more than 25 publications. Our second moderator will be Dr. Premraj Singh Sir. He is an additional professor in King George Medical University with a PG teaching experience of 8 years. He has specialty interest in pediatric anesthesia. He is a holder of BLS and ACLS instructor, ATLS instructor, and Secretary of Lucknow ISA, Secretary of UP, Indian Association of Pediatric Anesthesia, Vice President of SEMI Society Center, KGMU. He holds 18 publication and 2 chapters. I would now like
So
to...
we welcome this faculty. We welcome our esteemed faculty today because the topics are according to their area of interest.
Thank you, sir. Thank you, sir.
Welcome you both, sir. I would now like to explain a few instructions before starting the session and handing over. I request all to keep the audio muted for duration of talk and keep the videos off. All the queries should be posted in the chat box and will be answered by the end of the session. Now I humbly request ma'am to take over the session. Welcome, ma'am.
Thank you, Dr. Smita, and very good evening, everybody. At the outset, I would like to thank you, Dr. Bajwa, Dr. Madhavi, and everybody in the team to giving me this opportunity. And as Dr. Bajwa said, that the pediatric anesthesia or these subset of populations need extra vigilance, and so more so in the cases when the cases come to us with a common cold or upper respiratory tract infections. And we all have a lot of queries regarding this topic, whether we are always in utter confusion, whether we should take up this case or whether we should, cancel this case. So hopefully discussion today will solve many queries of PGs and ourselves also, because every topic which is discussed anytime is a learning experience both for the teachers and the students. So first, I would like to introduce Dr. Amita. She will be taking up a case of a child, anesthetic management of a case of a child who is presenting to us with the symptoms of upper respiratory tract infection. Dr. Amita is a JR third year in the Department of Anesthesia at KGMU Lucknow. Dr. Amita, and you can start the case. Over to you, Dr. Amita.
Dr. Amita, you can start your session.
Hello.
Yes, ma'am. Yes, ma'am.
For the audience, we have taken up some MCQs also, which will be doing after the case scenarios and the whole discussion. And the audiences will reply in the chat box. Amita, are you ready?
Yes, ma'am. Just a second, ma'am.
I think there are 2 devices nearby. That's why the sound is getting echoed.
Hello?
Hello. Am I audible now?
Amita, your sounds are coming with echo. So I think there is another device nearby which I must have logged in. So you can turn off the other device.
Okay, sir.
This is fine. The slide is visible.
Am I audible now, sir?
Yeah, better.
Good evening. I am presenting a case of URTI with pediatrics anesthesia. I am presenting a case of a 1-year-old male child who presented with a complaint of swelling in the right inguinal region, which was noticed since 1 month. History of presenting illness. Patient was apparently all right 1 month back when the mother noticed a swelling in the right inguinal region, which was of the size of a pea in the groin region. The swelling reached the bottom of the scrotum on coughing and crying. and it disappeared on lying down. This swelling was not associated with any pain, vomiting, abdominal distension, constipation, or fever. There is history of runny nose and mild cough since past 7. Just a second, sir. I have shared the wrong slide, sir. There is history of runny nose and mild cough since the past 7 days. The discharge was clear, non-mucoid, and not green in color. The cough is dry and non-productive. There is no history of fever, and the child is feeding well. Currently, the symptoms of URTI have improved with supportive care, and there is no history of any medication. Past medical history, there is no history of any ATT intake or any previous surgeries. Birth history, it was a full-term normal vaginal delivery, and the baby had cried immediately after birth. There is no history of cyanosis or any NICU admission. Development milestones are appropriate for the age, and the immunization status is up till date. On general physical examination, the weight of the child is 10 kgs, and on general appearance, the child appeared alert, playful, well-nourished. The vital signs, there was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or any edema, and the patient was afebrile. The respiratory rate was 24 breaths per minute, and the heart rate was 110 beats per minute. On respiratory examination, bilateral lung fields were clear on auscultation. There was no wheeze or no crackle, and there is only history of mild nasal congestion, which was noted. The abdominal examination, abdomen was soft and non-tender on examination. There was a swelling of size 2 by 2 centimeters in the right inguinal region. It was non-tender and reducible and became prominent when the child cries or coughs. There is no sign of incarceration or strangulation. And other systems were unremarkable. Summary, there is a 1-year-old male child who is presenting with complaint of right-sided inguinal hernia since 1 month, and there is history of recent upper respiratory tract infection for the past 7 days, and this child has been posted for elective herniatomy.
Sir, is your case done? Amita, am I audible?
Just a second, ma'am. Hello?
Are you audible, beta?
Yes, ma'am.
Okay. Now, so you have presented a case of a 1-year-old male child with a history of recent upper respiratory tract infection and coming to you for a elective herniatomy. Okay. Can you change the slide? Okay. So as we discussed right just now, that the patients in the PHC clinics usually we encounter are coming to us with the common cold or upper respiratory tract infections, and under age 4 years, they may have an average episodes of up to 6 to 8 URTIs per year. And the incidence may rise up to 45% of the children who are presenting for elective surgery. And usually the symptoms of URTI exist up to 7 to 10 days, but they may persist up to 3 weeks. So now, question for you is, Amita, that define URTI. What are the signs and symptoms, and what are the pathogens which are responsible for URTI?
Dr. Amita, you're not audible.
Am I audible now, ma'am?
Yes.
Ma'am, there is no definitive definition for URTI, but it is a cluster of symptoms which includes any two of the following. Most commonly, we have rhinorrhea, then nasal congestion, sneezing, productive cough, any sore or scratchy throat, then history of malaise or fever more than 38 degrees. But ma'am, mostly there is a combination which is found. Mostly it is fever with productive cough, which is found in 45% of the patients. And secondly, we have fever, which is associated with nasal discharge.
It is responsible for Is Amita audible?
Yes, ma'am.
So please speak.
You have to unmute yourself.
Mamta ma'am, you're not audible. Dr. Shreya, you're not audible.
We both are not audible.
No.
Now
Yeah, now you are
audible.
audible.
Amita, you are not
Okay.
audible.
Now you are audible, ma'am.
Amita, don't mute yourself, please.
Yes, ma'am.
What are the pathogens responsible for URTI, Amita? Can you mention that?
Okay, ma'am. Ma'am, please repeat.
What are the pathogens responsible for your upper respiratory tract infections in pediatric setup
Ma'am,
population?
URTI can be caused by bacterial as well as viral infections. Most commonly, we have found the association of rhinoviruses, which is followed by para-influenza virus and influenza type A and type B. And also there is association of group A beta hemolytic streptococci. And one more is the respiratory syncytial virus. Although incidence of respiratory syncytial virus is less, only 6%, but it causes a severe form of respiratory tract infection if it occurs.
Most commonly, these children are presenting with the viral infections, but commonly they can also have super-headed bacterial infections. Why it is important to know about the viruses? Because among these viruses, the rhinovirus is the most common, but the respiratory syncytial virus can present with a serious infection. So this is a kind of a red flag sign for the anesthetist as well as the surgical team. Okay, coming to the next question. What are the perioperative risk factors which are associated with upper respiratory infections in pediatric patients undergoing anesthesia? Can you elaborate on that, Amita?
Yes, ma'am. Ma'am, the perioperative risk factors which are associated with the upper respiratory tract infections are, ma'am, mostly associated with laryngospasm, bronchospasm, which causes major risk factors. Secondly, there can be oxygen desaturation during the course of surgery, and there can be history of coughing as well. We have also found that the incidence of breath holding spells have increased because of the upper respiratory tract infections. Also, there is atelectasis or post-intubation group may also be found in such patients. And there is also history of pneumonia thereafter. And sometimes there can be unanticipated tracheal intubation, or there can be chances of reintubation after we have extubated the patient. So, ma'am, these are the risk factors.
So if there's a take-home message from this slide, I can say that for all the patients who are coming with viral infections or URTI, either viral or bacterial, basically these are increasing the risk of your bronchial hyperreactivity and your airways are becoming more hypersensitive. So there's a higher incidence of laryngospasm, bronchospasm, as well as all these conditions in these kind of patients. Okay. Okay. Thank you. Coming to the next question. Please change the slide.
Yes, ma'am.
Can you describe the pathophysiology of upper respiratory tract infections and how are they influencing these risk of these perioperative respiratory adverse events you have just mentioned in the last slide?
Yes, ma'am. Ma'am, because of the viral invasion, they invade the respiratory epithelium, which in turn causes inflammation of the respiratory mucosa and later lead to edema. Ma'am, the viral neuraminidase, they damage the ciliary apparatus and the mucosal epithelium. They also affect the autonomic nervous system, and there they inhibit the cholinergic muscarinic type 2 receptor, which in turn causes increased release of acetylcholine, which causes bronchoconstriction. There is also release of, ma'am, tachykinins and neuropeptidases. Plus, there are inflammatory mediators like prostaglandins, bradykinins, histamines, which in turn increase the bronchoconstriction. So, there is constriction of the smooth muscles of the respiratory tract, which causes bronchial hyperreactivity, and this can persist from 3 days and last up till 6 weeks.
Okay, so basically, a lot of chemical mediator release is happening here, which can cause the bronchoconstriction. One thing to be remembered here is that the bronchial hyperreactivity, which you said, it can persist from 3 days up to 6 weeks. Even it may persist more or longer, even if your symptoms have subsided. So we should always have this mind that even the symptoms are not there, but these pediatric patients are more prone for the bronchial hyperactivity, especially when airway manipulation has to be done. Okay.
Yes,
now coming to the next question, can you change the slide, please?
Yes, ma'am.
Okay. Further, please. So my next question is, how will you assess this patient in preoperative period?
Yes, ma'am.
Okay. Before coming to the preoperative assessment, you can also discuss. Okay, please come back to this last slide.
Ma'am, just a second, ma'am. I'm not able to hear you. Ma'am, please repeat.
Okay. What my question is, I'll ask the preoperative assessment later on. Can you tell me the factors which should be considered when deciding whether to proceed with? No, you tell me the risk factors which are responsible for the occurrence of perioperative respiratory adverse events in children with upper respiratory tract infection. Can you mention these?
Yes, ma'am. Ma'am, the risk factors for occurrence of perioperative respiratory adverse events in children depends on, ma'am, three factors. First, the patient factors, then the factors associated with the surgery, and thirdly, anesthesia-related factors. For the patient, most important is the age of the baby. If the baby is younger, then there are increased chances of perioperative respiratory adverse events. Or if there has been a history of prematurity, birth at less than 37 weeks of gestation, or if there is history of, ma'am, passive smoking or parental smoking, or, ma'am, if has been a history of reactive airway disease, bronchial asthma in the past, or bronchopulmonary dysplasia, or any cystic fibrosis, or, ma'am, if the patient is having active URTI with copious secretions and is having productive cough, or if the parents themselves are saying that the child is sick and they believe that the child is having active cold. So these are the patient-related factors. With regards to the surgery-related factors, it depends upon the surgery. If the surgery is related with the airway, then there are increased chances of perioperative adverse events. Or if the surgery is associated with ENT surgeries, ear, nose, throat, or any ophthalmic surgery, or if it is involving the abdomen, especially the upper abdomen, or if there is any thoracic surgery. With regards to the anesthesia-related management, ma'am, it depends upon the expertise of the anesthetist. If we have a trained anesthetist who has faith in himself or herself, then we can have good results. Or if it also depends upon the device which we are using, whether we are using endotracheal tube, or if we are using just a face mask to ventilate the patient, or LMAs are being used. And, ma'am, it also depends upon the agent which we are using, whether we are using inhalational agents or induction agents. Whether if we are using desflurane, then it is a very irritant to the respiratory tract. So we should avoid such things.
So for this PGs, I'm simplifying this. If they ask in case discussion, if you have been asked about the risk factors for the occurrence of perioperative respiratory adverse event, just remember there are mainly three you can categorize into three. One is the patient itself is a risk factor, depending upon the in what condition patient has come, what are the comorbidities, whether patient is having a spurious or greeny discharge, or what about the nasal congestion, or there is some prior history of reactive airway diseases. Then surgery, type of surgery also contribute to it. Then the anesthetic management, whenever there is a chances of airway manipulation in the form of endotracheal tube or bronchoscopy even, then the risk factors for this smoking.
Ma'am, you're not audible, ma'am.
Just
Mamta ma'am, you're not audible.
but
Mamta ma'am, you're not audible.
am I?
No, your voice is breaking.
Hello,
No, your voice is cracking actually.
Amita, am I audible now?
Yes, ma'am. But, ma'am, your voice is breaking.
Okay, my voice is breaking up. Okay.
Right now it is fine, ma'am. You are
Is
audible.
it better?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
Okay. I'm asking just in the risk factors, you have mentioned, Amita, that there's an impact of parental or passive smoking. So can you tell
Yes,
me
ma'am.
what are the reason or how does it impact your children with the URTs?
Yes, ma'am. Ma'am, already the patients with URTI have a hyperreactive airway. And if such children are already exposed chronically to smoke, they will have increased chances of hyperreactive airway. And there will be increased
Okay.
chances of secretion. And there are increased chances of airway irritability. And these kids also have increased incidence of developing asthma later in life. And overall, ma'am, it increases the risk of perioperative respiratory adverse events, and it can also stimulate bronchoconstriction during the time of anesthesia.
Am I audible now?
Yes, ma'am.
Okay. Now, this patient has come to you in a preoperative, in your preoperative PAC clinic. Now, how will you evaluate in the pre-anesthetic period?
Yes, ma'am. Preoperative assessment, mostly, ma'am, it depends upon good history taking and good clinical examination. So first we have to take the history, and we have to identify whether it is a complicated URTI or an uncomplicated URTI, whether it is mild, moderate, severe, depending upon the symptoms of presentation, and the physical examination, whether the child is having fever, tachypneic, audible, wheeze. So mostly it depends upon history taking and physical examination. But in cases when we are not very sure about a physical examination, then we can also go for laboratory tests, which include a chest X-ray. And we can also get a CBC run and get a total leukocyte count to know about the infection. And we can also send nasopharyngeal swabs and aspirates.
We can recognize the uncomplicated or complicated URTI in the preoperative assessment only. Do you really need laboratory investigations like chest X-ray in every case?
No, ma'am. Not in every case, ma'am. We can require a chest X-ray only if we have added bronchial infections, or if there are symptoms of lower respiratory tract infection, or if a physical examination is not very clear whether it is a moderate or a severe case. Mostly, ma'am, a good clinical history and a clinical examination are all right, because it can also cause a burden on the surgical team, because it is not always feasible to go for investigations.
So we basically need good history in clinical examination, laboratory test or investigation. You don't need some additional or investigation in this case. So now always we are all into the confusion that whether these patients should be cancelled or postponed or should be taken up. So can you describe me the factors which should be considered while deciding whether we should proceed with the surgery or we should cancel the case?
Yes, ma'am. Ma'am, the factors on which it depends whether we should go for the case or we should cancel the case, ma'am, it is multifactorial. First of all, it depends upon the parents' compliance, whether they are consenting for the procedure or not. Secondly, ma'am, it depends upon the type of surgery or upon the urgency or emergency of the surgery. If the patient requires an urgent, we will weigh the risk and the benefits of the surgery, ma'am. And then it also depends upon the expertise of the anesthetist. And ma'am, if the case has been postponed since the past few days, so it will also depend because we cannot indefinitely postpone any case. And ma'am, it can also cause emotional stress and inconvenience to the parents and as well as to the child, because if the child is school going, then it can also cause delay. It will determine is the child, whether the patient is having any comorbidities or if there is any prematurity.
Apart from these factors which you just mentioned, the frequency of episodes of URTIs should be considered also, because as you told that if child is a school going and suppose there are 6 to 8 episodes per year, your child will never be fit for to be taken up for the surgery. So frequency of episodes is also an important factor which should be considered apart from these factors. Okay. Now coming to the next slide. Okay, now you said that the patient factors are very important. So can you explain how the patient factor is important in deciding to proceed with the case or cancellation of the case?
Yes. Ma'am, patient factors mostly depend upon the clinical presentation of the patient, the history, if there are any comorbidities, physical examination, and vital signs. Plus, the most important thing is the consent of the parents. We can classify the symptoms according to mild cold, moderate cold, and severe cold. If the child is presenting with a runny nose, a clear runny nose with dry cough, and there is no fever, no wheeze, then we will classify it as a mild cold. But if the child is presenting with a runny nose, it can be purulent and moist cough, but the patient is not having fever, then we will classify it as a moderate cold. But if the child has a green, purulent, runny nose, mucoid in consistency with active productive cough, and there is wheezing, and there is fever, malaise, patient is not able to feed well, then we will classify it as severe cold. If the child is having severe cold, ma'am, we will not take the child for surgery, and we will postpone the surgery for 2 weeks and reevaluate the child if it is possible, if it is not an emergency surgery. Whereas if it is a case of a mild cold, mostly we try to do the surgery of the patient, and we can optimize the patient with inhalational steroids or salbutamol, and then we can proceed for the surgery.
What about the moderate? If the patient is having a moderate symptom like moist cough but purulent congestion is there, running nose but not the green secretions?
Yes, ma'am. Ma'am, if the patient is presenting with moderate cold, then ma'am, we will have to weigh the risk and the benefits, whether we have to do the surgery or not. Ma'am, the risk factors are if the child is less than 1 year of age, there is history of any passive smoking, or there is history of comorbidities, or if the surgeries of the airway and ear, nose and throat or eye surgery, or if the patient requires endotracheal intubation. Or ma'am, we will try to avoid the surgery in these cases. But if the child is of older age, more than 2 years, active, and has a good appetite, the rhinorrhea is clear, the lungs are clear, there is no history of any fever, then and there is no history of any comorbidities, then we can plan for the surgery, ma'am.
Okay, very good. So I think this algorithm is telling us, is clearing many queries for us. And that's why good history we were talking about is very essential, where can then differentiate based on the history and examination only that mild cough cold is there or a severe cold is there. Chest examination is must. If there's a wheeze, we can categorize it into the severe cold. Okay, good. Now, there's a cold score also. Can you explain the role of the cold score in assessing the risk of these perioperative respiratory events in children with URTI?
Yes, ma'am. Ma'am, cold score, it is a pre-anesthetic score. It is not a validated score, but we use it to assess the risk of perioperative respiratory adverse events. Ma'am, mostly it helps us to identify the red flags when not to take the case. Ma'am, it depends upon 5 factors. Ma'am, C stands for the current signs and symptoms. O stands for the onset of the disease. L, whether the child was having any previous lung diseases or not. D stands for the device which we are using. And S is for surgery. We have divided it into 3 classes where we are giving scores of 1, 2, and 5. And ma'am, the total score ranges from 5 to 25. As the score increases, then the chances of perioperative respiratory adverse event also increases, ma'am.
So cold score is basically giving us an alert to the anesthetist as well as to the surgical team that even if the patient has to be taken off surgery, each patient should be categorized as a high risk category. Okay, fine. Now, what should be the optimal timing of elective surgery in these children with recent URTI? Because at what time the elective surgery should be taken up, it's a matter of debate for years and years. So what's your take on this?
Ma'am, the optimal timing will depend upon the features and the signs and symptoms of the child, because previously, ma'am, in the olden days, there used to be blanket cancellation of these patients and they used to postpone the surgeries for 4 to 6 weeks. But ma'am, the mere definition and incidence of URTI have been found to be 68 episodes in 1 year. So if we are going to wait for 4 to 6 more weeks, then it is not possible, ma'am. Then the surgery will be deterred for indefinitely. So it is that is why after a lot of studies, we found that there is no need to delay the surgery for 4 to 6 weeks, but we can postpone the surgery for 2 weeks and then reevaluate if we can go for the surgery or not. Plus, ma'am, it also causes emotional stress to the patient because patient may be traveling and it can be very distressing for them sometimes, and the mere procedure of traveling also exposes their airway to reactive substances, ma'am. And ma'am, even they say that this can persist for up till 6 weeks. It is not clear cut because later on also such children have predisposition for hyperreactive airway. So the risk of perioperative respiratory adverse effect can be still present because of the inherent condition of the patient. But ma'am, most of the pediatricians will try to do that.
Obviously, that means the patients with a mild cold or a moderate cold, they can be taken up for the surgery, taking all precautions, which we will discuss further. And severe cold should be, if required, to be postponed for at least 2 weeks, and then can be reviewed and patient can be taken up later on, so that the impact of the patient or family or healthcare system can be lessened up. Okay.
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Let's discuss we have discussed the preoperative part and all. Now coming to the intraoperative part. Now, what should be the goals of such patients when coming to you for this patient coming to you for a hernia?
Ma'am, the goal for the anesthesia management is to reduce the amount of secretions, and we have to limit the stimulation of the reactive airway.
Okay. Now we'll discuss the intraoperative management in detail. So how will you pre-medicate this child? He's a 1-year-old. He or she's a 1-year-old child of 10 kg. Now, in the preoperative area or in the OT, how will you pre-medicate this child?
Yes, ma'am. Ma'am, for pre-medication, we can. It is based upon many trials, ma'am. They have found that we should try avoid using benzodiazepines as pre-medication because they had found that there were increased incidence of delayed awakening, and the chances of laryngospasm increased after the use of benzodiazepines. This is for sedation, ma'am. But we can, as an alternative, use oral clonidine for pre-medication. Plus, it is ideal to nebulize the patient with bronchodilators like levosalbutamol or salbutamol at least 10 to 30 minutes before taking the patient into OT. And ma'am, research has found if we combine the beta-2 agonist with the corticosteroids, they are more effective as compared to using beta-2 agonist alone. As regards to glycopyrrolate, ma'am, they have found that if we give glycopyrrolate IV after induction, there is no role because we use it mostly because of the anti-sialog property. Then, ma'am, bronchodilators, ma'am, we can use, if the child is less than 20 kgs, we can use it in the dose of 2.5 mg. But if the child is more than 20 kg, we can use it for 5 mg. With regards to the airway management, ma'am, it is non-invasive ventilation is better as compared to any invasive technique. So, am I audible, ma'am?
Yes, you're audible.
Yes, ma'am.
I think first let's take up the pre-medication first and we'll come on to the intraoperative management. Otherwise, everybody will get confused. You said that we should avoid the benzodiazepine for pre-medication because it is increasing the risk of laryngospasm. If suppose we don't have the clonidine, do you know about any other alternative which we can give?
Ma'am,
suppose patient is very anxiolytic, is very anxiety.
Ma'am, ketamine. We can use ketamine. IV ketamine can be used, but ma'am, it increases the secretions of the child, so we better avoid it. But if the child is agitated and we need to take an IV line, then we can use inhalational anesthesia as well, just for taking the IV access.
Okay, or for the pre-medication part, I'm saying that we can also take the intranasal dexmedetomidine.
Intranasal.
It's an also a good alternative. Okay, and can come to the next slide. You said about the preoperative salbutamol. Can you explain again that how does preoperative bronchodilation administration will impact the risk of your preoperative respiratory adverse event?
Yes, ma'am. Ma'am, using beta-2 agonists like salbutamol, ma'am, at least 10 to 30 minutes before, ma'am, it reduces the overall. They have found that overall reduces the perioperative respiratory adverse events, and there is decreased incidence of coughing or bronchospasm also intraoperatively. And if we are combining it with corticosteroids, then it causes good bronchodilation. And intraoperatively also, the pressures will be low and ventilatory settings will be fine, ma'am. And ma'am, secretions will be less because we have already optimized the patient.
What about the use of IV glycopyrrolate?
Ma'am, IV glycopyrrolate, ma'am, we give it before to decrease the secretions, but ma'am, studies have found that there was no role after induction. They did not find that glycopyrrolate was effective, or it did not have any effect on the perioperative respiratory adverse events, ma'am.
Okay. And what is the role of topical lignocaine in reducing laryngospasm? Can you mention that?
What, ma'am?
What is the role of topical lignocaine? Can it reduce laryngospasm?
Yes, ma'am. Yes. Ma'am, topical lignocaine, ma'am, they had found because ma'am, topical lignocaine we are giving before induction of anesthesia. So ma'am, it will become an irritant for the airway. So the child can go into laryngospasm. So they had found there was no role of any topical lignocaine. But they found that if we are putting lignocaine jelly on the supraglottic airway device, it was helpful. Although it did not reduce, but it was helpful, better than the topical. We can also give IV lignocaine, but it is not very effective, ma'am.
So according to you, the best technique for, best recommended technique in a preoperative period is the salbutamol, which can be given either through the spacer or we can also nebulize the patient. It should be done around 10 to 30 minutes prior to the induction. Okay, fine. Now coming to the anesthetic technique, what do you think? The IV induction agent is a good technique or inhalational agent for technique?
Ma'am, Ma'am, they had found that IV induction is better as compared to inhalational induction. And among the IV induction agents, propofol was found to be very beneficial because it has good airway reflex blunting ability. So there were decreased chances of laryngospasm and bronchospasm as compared to other ketamine or thiopentone. With regards to ma'am, volatile anesthetic agents are very good bronchodilators. So they can be used during maintenance of anesthesia as compared to induction. And if we have to use inhalational induction, if we are not able to use propofol, we are not, if the child doesn't have an IV line, if we are using inhalational induction, then our choice should be sevoflurane because it is a sweet smelling and less irritant as compared to desflurane because it is very pungent smelling and irritant and causes increased resistance to the respiratory system.
My students is
Ma'am, your voice is breaking, ma'am.
Hello.
Your voice is breaking, ma'am. You're audible, but your voice is cracking.
I'm just sitting next to the internet. Now is it audible or not breaking up?
Yes, ma'am.
So if I compile it for the PG residents, the thing is that your choice of drug for the induction is propofol, and because it suppresses your airway reflexes better than your inhalational agents. Though inhalational agents are better bronchodilators, but propofol is a better airway reflex suppressing agent. And for the inhalation agent, if I go by the choice of agent, the sevoflurane is the best as compared to the desflurane or halothane. And this is the case. Intravenous is the best as compared to the inhalational induction agent. And what about when we go for the airway manipulation, what is your take on the supraglottic airway devices versus your endotracheal intubation? Which you think should be better?
Ma'am, always non-invasive ventilation is better. So if we are able to ventilate the child with a simple face mask, then it is best. But if we have to use between the choice of a supraglottic airway device or an endotracheal tube, we consider a supraglottic airway device to be better because there is less airway manipulation. And studies have found that ET tube has increased approximately 11 times more risk of perioperative respiratory adverse events and bronchospasm later. And perioperatively, post-operatively also, such patients are at increased risk of developing such cases.
So I would like to add here is that if you're using, if you can use LMA if possible, then go for your preferred choice should be your supraglottic airway devices. But where the ET tube is necessary, then please go for the cuff tube rather than the uncuffed tube rather than the cuff tube, which also decreases the airway stimulation. So this is for the LMA versus ENT. Now, you have told us about the death prevent. So what are the, now the patient has, is towards the end of the surgery, patient needs extubation. So what do you think that should be the plan? Whether patient should be extubated in the deep planar or patient should be fully awake? What we should be done?
Ma'am, there is no fixed consensus about whether the extubation should be done awake or it should be done in a deeper plane. Although suctioning should be done in a deeper plane so that there is no airway hyperactivity. But ma'am, a few school of thought believe that we should go for an awake intubation because this enables the child to clear their own secretions and their reflexes are patent. So few of them believe that the child should be awake and then we should extubate. But ma'am, a few people think that few anesthetists believe that the child should be extubated in a deeper plane in order to avoid the same reflex airway constriction.
So that means the optimum depth of anesthesia for extubation of trachea is, there's no difference in the incidence of complication. One thing I would like to add here is whenever we have to suction these patients, we should suction the deeper plane of anesthesia. Otherwise, for mild to moderate patient can be, extubated fully awake, fully kicking. So I think the message is clear. And any post-operative concerns in such set of patients?
Children with URTI who already have such risk of developing perioperative respiratory adverse events, ma'am, perioperatively and postoperatively, at both the times, they can develop the same symptoms later. Although laryngospasm is exclusively an intraoperative procedure, still the child can desaturate later in the postoperative room. There can be complaints of bronchospasm, or the child may have post-extubation croup or cough. So these children can later develop asthma or they can have recurrent wheezing. So it is better that when we are shifting these patients post-operatively, so we have to monitor these patients and we can shift the patients on oxygen.
Yes, we need to shift these patients on oxygen. The monitoring should be strict. We should be quite vigilant about any post-operative concern, the complication you have just discussed. And patients should be well hydrated, and there should be an adequate pain management also should be done. Okay. Now, can you come back to the algorithm? Can you describe this? This is your approach to a patient who is coming to us with the herniottomy or any other surgery. So for PG testing, can you just in few minutes can you explain it in once again so that approach should be clear?
Yes, ma'am. Yes. Ma'am, if any child is presenting with to us with upper respiratory tract infection, first we should take a good history, then ask about the comorbidities, passive smoking. Then we should do a good physical examination of the child, and then we should see the vital signs of the child, whether the child is having tachycardia, fever, respiratory distress, and then we should also take consent and the statements of the parents, whether they believe that the child is having cold or not. Then, ma'am, we can classify. This is the stratification. We can classify them as mild cold, moderate cold, and severe cold. Accordingly, we can postpone or plan to take the patient for surgery. If it is a mild cold, there is no, a clear runny nose and there is dry cough and there is no fever, no wheezing, then we can take the patient for surgery with optimization of the patient, whether we want to nebulize the patient with salbutamol And during the course of the surgery, we would try to avoid endotracheal intubation. If we are able to use a supraglottic airway device, then we can proceed with that. And if we can perform the surgery with bag and mask ventilation, it is a good option. Then we should avoid pungent or irritant inhalational agents like desflurane, and rather our choice should be sevoflurane. Then inhalational induction should be the choice of our anesthesia. We can use propofol, and we can also use lignocaine jelly, because and try to avoid topical lignocaine. If it is a case of moderate cough, moderate cold, the child may be presenting with a runny nose with purulent discharge, and there may be moist cough, but the child will not be very toxic looking. The child will not have fever. The child will not have wheeze. So we have to weigh the risk and benefits of the surgery. If the child is of older age group, there is no history of prematurity, child is playful, child has no respiratory comorbidities previously in the past, then we can plan to take the child for surgery. But if the child has risk factors, if there is history of prematurity in the child, passive smoking, previous comorbidities, bronchial asthma, or if the surgery is involving the respiratory tract or any ENT surgery, or if it is a complicated thoracic surgery or upper abdominal surgery, then we have to wait. Then again, we can, the post-operative steps will be the same. But if the child is presenting to us with severe cold and the child is having copious secretions and purulent mucoid discharge from the nose, child is having fever, malaise, not feeding well, and is not active, has bilateral rhonchi, wheeze, then ma'am, we should, it is better that we postpone the surgery and we will reevaluate the child after 2 weeks.
I think approach guide to the anesthetic management of the child is clear, and well done, Amita. You've done good job. We are really sorry for some technical glitches which was coming in between. And over to you, Dr. Patil.
Yes, ma'am. Thank you, Amita. Thank you, ma'am, for an excellent session. I would like Dr. Prem sir to take over the session.
Very well presented, Amita. I think
sir.
it's going to be very helpful to the residents listening this case presentation. So first, I want to thank ISA National Bajwa sir for giving ISA Lucknow this opportunity. As we all know, tracheoesophageal fistula is a challenging case for anesthetists, as they come present in early age of life, and there is a chance of difficult intubation, ventilation, and perioperative management is very important in tracheoesophageal. So we are going to discuss about all these things in this case going to present by Shreya Rastogi. She is JR3 in Department of Anesthesia and Critical Care at King George Medical University, Lucknow. Over to you, Shreya. You can start.
Good evening, sir and ma'am. I am presenting a case of tracheoesophageal fistula. A 2-day-old male weighing 3 kgs who was delivered at 36 weeks of gestational age presented to us with complaints of copious white frothy bubbles of mucus in mouth and nose since birth, and 1 episode of choking and coughing associated with first feeding given on birth. History of presenting illness. History was given by patient's mother and seems to be reliable. Patients presented with copious white frothy mucus bubble in mouth and nose. He had episode of choking, coughing associated with the first feeding, and thereafter patient was not fed. The on-call pediatrician was unable to pass orogastric tube. There is no history of bluish or yellowish discoloration of skin, any limb or facial deformity, anal canal defect, or recurrent respiratory tract infections. Antenatal history, the mother was elderly gravida and was of 34 years of age. She was primiparous. Her first trimester history was uneventful. The blood glucose levels, which are considered a risk factor for development of tracheoesophageal fistula, were within the normal range. The second trimester history was also uneventful. During the third trimester USG scan, she was found to have polyhydramnios. Patient underwent preterm premature rupture of membranes, and because of maternal request was taken up for a cesarean section. Birth history, our child was late preterm, was delivered at 36 weeks of gestational age via lower segment cesarean section. He cried immediately after birth, weighing and weighed 2.7 kgs. There was no history of meconium staining of amniotic fluid. Urine was passed 1 hour after birth and stool after 24 hours of birth. The immunization status was child was up to date. Journal examination, neonate was examined in a well-lit warm chamber after the consent from mother was taken. He was lying in a flexed position. He had a soft cry, sleepy with poor spontaneous activity. Vital parameters were within normal range. Capillary refill time was also less than 3 seconds. The anthropometry measurements and head-to-toe examination revealed no abnormal finding except the inability to pass orogastric tube beyond 11 centimeters. The airway examination, CNS and cardiovascular examination was within normal limit. Respiratory system showed that patient had chest retractions, but bilateral air entry was present and it was clear. Abdominal and spine examinations were also within normal limits. Lab investigation showed hemoglobin of 16.8 gram%, platelet count of 2.43 lakhs, TLC count of 14,500, serum electrolyte, even a screening 2D echo was done and was found to be within normal limits. This is the chest X-ray of the patient. It shows here the coiled orogastric tube, which is characteristic finding of tracheoesophageal fistula. The summary of my case is a 2-day-old neonate presented with chief complaints of copious white frothy bubbles of mucus in mouth and nose, episodes of choking, coughing associated with history of inability to pass orogastric tube, and chest X-ray PA view showing coiling of orogastric tube suggestive of tracheoesophageal fistula.
Okay, Shreya. So this is a case about tracheoesophageal fistula. My questions to you: what is tracheoesophageal fistula, and what are its incidence?
So tracheoesophageal fistula is an abnormal connection between trachea and esophagus. The incidence is found to be 1:4,000 live birth, with male is to female preponderance of 25:3. It's been 10 to 40% more commonly in preterms.
Okay, so it is more common in male than compared to female.
Females.
Okay. So what is the embryology of this tracheoesophageal fistula?
So foregut arises from primitive endoderm and it divides into trachea and esophagus. Lung around 4 to 6 weeks of gestational age. Lung buds form anteriorly at pharyngeal arch 6. There are expression of various growth factors involved, which results in foregut developing anteriorly, which translates into trachea and lung tissue, while posterior portion forms esophagus. Then a septum forms between the trachea and esophagus, which requires multiple gene signals, including sonic hedgehogs or SOX2 and NKX 2.1. Usually, it is found that error of the septa formation because of the abnormal gene signals lead to formation of fistula.
Okay. So this is a gross classification. Can you explain the gross classification? What?
Yes, sir. So gross classification divides tracheoesophageal fistula into 5 types. The gross type A is pure, where proximal and distal esophageal stumps are found. The mid segment is missing, but our respiratory system is uninvolved. It's found only 7% of the time. In type B, the proximal esophageal pouch is connected to trachea, while distal esophagus is ending into a blind pouch. It is seen in lesser patients with 2%. Type C is the most common, where the proximal esophageal pouch ends blindly and the distal esophageal pouch is arising from the trachea itself. It's seen 86% of the time. Type D is where both proximal and distal esophageal pouch are ending as well as arising respectively from the trachea. Type E is the H type. This is the only type, sir, in which the orogastric tube might pass because the esophageal atresia is not there. The esophagus is connected to the H type fistula. Similarly, sir, one Vogue classification is also there. The type A of Vogue classification corresponds to gross type A, and type 3C corresponds to gross Vogue type E, sir.
Okay, so type C is most common. So can you explain how does polyhydramnios in neonatal period correlate with tracheoesophageal fistula?
Sir, amniotic fluid, it's formed by the urine of the fetus, and its consumption is via the swallowing of the fetus. In tracheoesophageal fistula, since the swallowing is hampered, the fetus keeps on passing the urine, which leads to increase in the amount of liquor, ultimately leading to polyhydramnios.
Okay. Also, if these patients come for the PSC, also what are the clinical features? How you diagnose this is a TF?
So clinical features involve copious amount of secretions. The episode of, if first of all we can diagnose it prenatally also, sir. Prenatally, what we see is patient will be polyhydramniotic, plus there will be an absence of fundic bubble seen in the USG. These are all non-specific findings, but can cause a doubt that child might have tracheoesophageal fistula. Postnatally, the child will present with copious amount of secretions, which will keep on coming even after intermittent suctioning. There will be excessive salivation, coughing, gagging, choking, cyanosis, and regurgitation if by mistake patient is attempted to be breastfed. The pulmonary aspiration of gastric contents would lead to atelectasis and pneumonitis, and child may present as with a picture of ARDS. The failure of passage of catheter down to the stomach is diagnostic, except in type E. The diagnostic confirmation can be done by a chest X-ray where catheter is seen coiled in a blind upper pouch, sir.
Okay, yeah. Or sometimes it is seen that these children present with vectoral abnormalities. What are those vectoral?
Sir, vectoral abnormality is a group of abnormalities in which vertebral anomalies are seen. Vertebral anomalies like hemivertebra can be seen, apoplasia can be seen, anorectal abnormality is seen, tracheoesophageal fistula can be there, rectal anomalies can be seen, radial hypoplasia can be there, sir.
Okay.
Sir,
So-
cardiac anomalies like BSD, ASD, tetralogy of Fallot and PDA can also be seen in such cases.
So how you diagnose preoperatively? So what are the assessed risks in preoperative in tracheoesophageal fistula cases?
So preoperative risk assessment is usually done by two classification, it's Spitz and Montreal. Spitz classification, and we have to see birth weight, if any cardiac defect is present, and then we can predict the survival of the child. In Spitz group 1, the birth weight is more than 1.5 kg, there's no major cardiac defect, and survival is 96%. In Spitz group 2 and 3, birth weight in both are less than 1.5 kg, but Spitz group 2 does not have any major cardiac defect, and thus the survival chances increases to 79%. In Spitz group 3, there are major cardiac defect, and thus survival is around 38%. So the Montreal classification has been recently used because there are advances in neonatal ICU care, and we hope to have a better outcome because of these advances. That's why the birth weight is no longer taken as a risk factor for mortality. High risk are those infants who have life-threatening anomalies. Low risk are all other infants without any anomalies, sir.
Okay. So what will be your anesthetic consideration for this type of cases?
So anesthetic consideration, mine will be that child is a preterm. The physiology of a preterm child will be entirely different. It will be difficult to position an endotracheal tube because of the presence of fistula. We should keep in mind that patient fistula has not to be ventilated. Patient, because is NPO, since the moment he is diagnosed, there might be dehydration if the IV fluids are not appropriately replaced. Patient may present with preoperative respiratory distress because of regurgitation and aspiration of the secretions. They are more, since they are preterm, they are more prone to hypothermia, hence they should be covered well, and there might be associated anomalies which might affect my management, sir.
So what will be your pre-anesthetic consideration and anesthetic consideration in PSC? What will things you will look for in this patient, and what will be your preoperative management?
So for pre-operative management, as soon as the diagnosis is made, in pre-anesthetic checkup, I'll rule out if any other vectoral anomalies are there. If I'll find out the order of the birth, if it's to find out the possible etiogenesis of the cleft for tracheoesophageal fistula. Chest X-ray, routine investigations, including a chest X-ray and screening 2D echo to be done. The moment the diagnosis is established, the child has to be kept nil per oral. He should be kept in a warm environment with head elevated up to 30 degrees to minimize reflux through fistula, or in a prone position with head up. A nasogastric tube to be placed in proximal esophageal pouch with repeated suctioning. If the child has already aspirated, there will be microaspirations, so antibiotics to treat pneumonia should be started. At least one pint PRBC should be cross-matched and should be available in the blood bank. If possible, an arterial line should be placed ideally in the NICU. Central venous access is not recommended until and unless the surgical team is planning to start the patient of total parenteral nutrition. An one IV cannula is sufficient, and rest we can take once the patient has been given general anesthesia. Routine preoperative intubation, it's seen that it does not help the child with aspiration of gastric content through the fistula.
Okay. So once PSC has been done, patient has been taken into operation theater. So how you are going to secure the airway? Because it is very important tracheoesophageal fistula for securing the airway. So how you are going to secure the airway in this case?
So in securing the airway, my primary goal is to have minimum possible inspiratory pressure to allow adequate gaseous exchange. We have to avoid atelectasis, we have to avoid the distension of the abdomen, and we have to avoid positive pressure mask ventilation. There are several ways to do so. The most commonly used technique is inhalational induction, or we can induce general anesthesia with inhalation induction and maintain spontaneous ventilation till an adequate depth to facilitate intubation. An IV induction agent can also be used. The positioning of the tip of ETT tube is a tricky part. What we usually do is we fully insert in the right bronchus, and then we slowly withdraw the endotracheal tube, and we fix it at the point where we hear bilateral chest entry, air entry to be equal. The ETT tube should be placed distal to the fistula, but proximal to carina to facilitate to do so. One other method of checking ETT tube is, if suppose a gastrostomy has already been done, we can see if the bubbles are generating or not. That also shows that our ETT tube is in the correct place.
Okay, it also recommended to use pediatric bronchoscopy. This is the correct placement of endotracheal tube.
Yes, sir. It is recommended to use the pediatric bronchoscopy if available. The role of bronchoscopy guide the surgical technique. It can also detect the presence of tracheomalacia or detect the presence of second fistula. It also helps to see if there are multiple fistulas, so that even if patient presents later to us in post-op, we can differentiate between a recurrent fistula or this fistula was present beforehand only. If a fistula is seen and can be occluded using a 3.5 Fogarty occlusion catheter, we should go ahead with it, because it allows us to give positive pressure ventilation without distending the abdomen, sir.
Okay, good. So once secured the airway, then there are chances of, when you're doing ventilation, then positive pressure ventilation is a risk for this patient. So how you're going to avoid this?
Sir, positive pressure ventilation is risky for this patient because via the fistula, the abdomen can get distended, thus leading to hypoventilation of the patient or even sometimes gastric rupture. Plus, it will add to the gastric reflux as well. It will add to the reflux as well. The best way to do is to not give pressure as possible. The patient should not be using a Jackson Reese. The patient should ideally be not placed on a ventilator and should be head ventilated. Sir, the muscle relaxant should not be given until and unless fistula is ligated. Ideally, it should be given once the fistula has been repaired.
Okay. So what would be your intraoperative consideration?
Sir, intraoperative management consideration will be to keep the child on spontaneous ventilation with inhalational agent till fistula is repaired. If muscle relaxant is given, we have to ventilate with the lowest tidal volume possible. Once we can take the patient on controlled ventilation with sevoflurane after the repair and once muscle relaxant has been administered. After fistula is ligated, anesthesiologist usually passes a catheter into esophagus and surgeon passes one from the stomach. These two catheters, using these as the base, the anastomosis is done, and the surgeon should keep in mind that it should not be a tight anastomosis, plus the sutures of the trachea and esophagus should be far apart to prevent further stricture and leak in the perioperative period. Hypothermia has to be avoided. Padding of pressure points should be done. The adequate hydration and glycemic control of the child has to be maintained, and we should be careful about the accidental extubations.
Okay, so how pain control in this patient? How are you going to manage pain? So what are...
So pain control, one of the criteria we use is whether we are planning to extubate the patient or not. If the patient is planning to be extubated, the dose of IV opioids has to be reduced. Otherwise, in a premature infant premature infant who is anyway at risk of developing apnea till 60 weeks of post-conceptional age will definitely develop it. So so lower dose of opioid is used if we are using planning to extubate. If not, then we can give it. Others are caudal epidural, which can be progressed till T6, T7 level. Intercostal nerve blocks can be used. IV paracetamol can be used. And since this child is around 36 weeks of age, 7.5 mg per kg of paracetamol 8 hourly till maximum dose of 60 mg is reached, sir.
Oh, good, good. So if you're planning to extubate, then it is fine. Then what are the indication of elective post-operative ventilation?
Sir, indication of elective postoperative ventilation from surgical side if esophageal anastomosis has been achieved under tension. This is one surgical indication of maintaining post-op ventilation. And if such a case is there, then the child has to be ventilated for 3 to 5 days electively, maintaining minimum peak inspiratory pressure. If there is a preoperative respiratory insufficiency, then we can do it. Neonates less than 2,000 grams should also be electively ventilated, sir.
Okay, and what are the post-operative complications?
So post-operative complication can be divided into early and late. The early complications are anastomotic leak. The late complication, mainly is anastomotic leak. The late complications are tracheomalacia, recurrent LRI due to aspiration, esophageal stricture, gastroesophageal reflux disease, and recurrent fistula, sir.
Okay, okay, sure. Very well presented case, Shreya. Now house is open for questions. If anyone want to ask question on this topic, Asmita.
Yes, sir. There are few questions in the chat box. Can we use rigid bronchoscopy to block
One second, Dr. Asmita, 1 second. Whether the madam and sir, you want to ask the MCQs?
MCQs, yeah.
Just we'll
Yes.
finish off with the MCQs.
Okay, ma'am.
Share, please share the
So
MCQ.
maybe you for this my MCQs are in other PPC.
Yeah. So what is the most common type of? Yeah.
Or Dr. Asmita, you can also ask. No question. No problem. Anybody ask.
This is
Sir?
for the audience, Asmita. You can ask.
Please ask.
Yes, ma'am. Most
Whoever's
common,
voice is audible. Yes.
most common type of tracheoesophageal fistula according to the GRAS classification is most of the answers are coming C.
Wait. Give them 30 seconds to answer. Wait.
Yes, ma'am.
हमारे questions करने पड़ेंगे ना.
Yeah. I think you can go to the.
Yes, sir. The most of the options in the chat box is type C. Next question, Dr. Shreya. Over to you, sir.
So the most common initial symptom of esophageal atresia or TOF is respiratory distress at delivery, projectile vomiting, hypoxia, coughing, and regurgitation after first feed.
You have a very dynamic response there. Many people are, many of the students are answering. Yeah.
That's good. That's good.
Most common chat box answer is 4, coughing and regurgitation after first feed.
Yeah, correct.
Sir, ma'am, I'll be sharing Amita's PPT for more MCQs.
Okay.
We have. Question number 1 back here. So for the viewers, the first question is mechanism of viral induced airway hyperreactivity or all except. So you have to mark the except. One is increased smooth muscle constrictor response to tachykinin. release of chemical mediators, action of viral neuraminidase on vagal nerve endings, and activation of M2 receptors resulting in increased acetylcholine release.
The most common answer in the chat box is option C, action of viral neuraminidase.
I tell the right answer, or should I wait for 20 more seconds?
Please tell the right answer, ma'am.
In the algorithm, we told you that M2 inhibition of M2 receptors results in increased acetylcholine release. See, all the changes which are happening in the causing the airway inflammation are both chemical mediator as well as the neurological reflexes there. So there is the action of viral neuraminidase on the vagal nerve ending, but inhibition of M2 receptors result in increase. So answer except is D. Coming to the question number 2. So what are the risk factors for perioperative adverse respiratory complications are? So there are 6 choices: nasal congestion, copious secretion, passive smoking, airway surgery, patient confirmation that the child has a cold, and history of snoring. So in the ABCD, we have made the different combinations. You have to tell us which combination is best or right. Everybody's answering right. That's so clear.
Yes, ma'am.
There is
Thank
nobody who is answering something different.
Yes, ma'am. Everyone is answering.
Yeah, everyone.
I know.
It's
It's
totally
sort
all
of
or none
unanimous
phenomena.
answers.
Either they've been
Yeah.
very clear or nothing is clear.
No, that means you
Okay.
have taught so well that they have understood
Oh,
it so well, looks like.
Okay, the answer is which is C. All are the risk factors which are responsible for perioperative respiratory complications. Can we move to the next case? The following statements apply to the anesthetic management of a child with the URTI. You have to tell the 3 true statements. Only one statement is false, is true, rest all are false. So one is the goals are to minimize secretion and limit stimulation of the airway. The airway should be suctioned after the child loses the eyelash reflex. Perioperative bronchodilator therapy with or without steroid has no role in attenuating bronchoconstriction triggered by airway instrumentation. And the general consensus is to remove the ETT away rather than D.
Correct. I think.
The maximum response is option A.
Maximum response is right. Somebody has mentioned D. I would like to clear here is that the airway should be suctioned. So,
Ma'am, your voice is cracking. You're audible, ma'am. Your voice is cracking.
I'm sitting. Okay with the time.
Ma'am, if you're not audible, Dr. Asmita can ask the question. Yeah.
Okay. That is right. Is there the question? Okay. I can ask.
Yes, ma'am. The following statements apply to the anesthetic management of a child with URTI. State the true statement. Sevoflurane is a better induction agent than propofol. B, an ETT should be placed used in preference to a LMA or a face mask to secure the airway. C, there is no difference. Yes. There is no difference in adverse respiratory events when the intravenous inhalation are used to maintain anesthesia. There is no difference in adverse respiratory events when intravenous or inhalational techniques are used for induction of anesthesia. There's a variety of response, ma'am, but the common being A and C. Mamta ma'am. The common replies are A and C.
But it's possible.
You're not audible, ma'am. Ma'am, you're not audible. Mamta ma'am, you're not audible. Anybody else can tell, sir?
Amita, you can answer.
Ma'am is not audible. You can just take over.
Amita?
The correct answer is D. Sevoflurane is not a better choice of induction agent than propofol. We had just studied that propofol is a better induction agent as compared to inhalational induction. The second statement that an ET tube should be used in preference to an LMA or face mask, this is also wrong because we studied that non-invasive ventilation is always better as compared to invasive ET tube. The third statement is there is no difference in adverse respiratory events when IV or inhalational techniques are used in maintenance of anesthesia. So this, and the last statement states that there is no change in induction of anesthesia. So this is wrong because we have found that the choice of IV induction is better during induction of anesthesia. So the correct answer is C, that there is no change if we are using IV or inhalational during maintenance of anesthesia.
Yes, can we go for the next questions, please?
Ma'am, that's it.
So, shall we
Okay.
proceed with the questions, sir?
Hello,
Yes.
ma'am, I'm audible now.
Yes, ma'am, you're audible.
Now
Is
we
that
can-
question clear or I need to do it again?
It's clear, ma'am. Amita,
Okay,
explain.
Okay.
Now we can take questions from audience.
Yes, sir. One of the questions regarding the URTA case was the use of dexmedetomidine, role of use of dexmedetomidine.
What is the question? Role of?
Dexmedetomidine.
Yes,
Dexmed.
Dexam is a now recommended drug of choice for pre-medication, especially the nasal one, and it has been found better than your clonidine even and even your midazolam. So because it also gives analgesic effect and it also causes the suppression of the airway refluxes. So they ask you that then the Dexmed is the better choice and dose is around 1 to 2 microgram per kg.
Okay, thank you, ma'am. The next question was, is there any dose of salbutamol for nebulization based on weight or age of the child?
I think we have discussed this. They have mentioned the salbutamol dose. If the weight is less than 20 kg, it is 2.5 mg, or if it is more than 20, then it is 0.5. It's about 5 mg. That means you have to give just 0.5 to 1 ml of the dose, depending on the weight, whether it's less than 20 or more than 20.
Okay. And the next question is, in a child with mild or moderate URTI, where will we take the intravenous access? In ward or OT, and with or without sevoflurane induction?
In the child with a mild to moderate URTI, depends upon the patient's separation anxiety. So the patient is calm, patient is cooperative, then you can take the IV in the preoperative area only, especially the child is older. But if the child is in the age of your 3 to 5 years of age or 2 years of age, then the child is, hyper anxious and you cannot take IV. Then either you take a topical, and topical anesthesia, and you can take the IV. Or if you have no choice, then you have to take the patient under the sevoflurane induction. For the mild to moderate URTI, it's fine.
Okay, ma'am. The next question says post-op is about post-op analgesics and regional anesthesia with general anesthesia, and the use of administration of regional anesthesia with general anesthesia. I think they want to
Yes,
ask.
it depends upon the surgery. We need to give a multimodal analgesia in pediatric patients also. Suppose patient is you're a candidate for caudal, you can go for the caudal anesthesia with GA, or you can also take the paracetamol suppositories. So we have to manage post-op analgesic regime depending upon the type of surgery and the area of surgery. So that can be done easily in these kind of patients.
I can add one more thing, like
Yeah.
this is inguinal surgery. So we can use ilioinguinal blocks, ultrasound
Yes,
ilioinguinal blocks,
yes.
and also so we can use suppositories.
Yeah.
Thank you, ma'am. Thank you, sir. So next is, how good is preemptive bronchodilator or anticholinergic nebulization helpful in preventing perioperative respiratory adverse events?
See, we already discussed the role of preemptive bronchodilators in the case of, in a cases for coming to do with the URTI. Usually the anticholinergic nebulizations, I think they're most commonly we use in the patients with the bronchial asthma. So in the preoperative area, I have not used, but ipratropium bromide, tiotropium bromide, they're recommended and probably can be given. If anybody else can add it, please. I have always used the salbutamol and others in the pediatric set of patients. Prem, can you add something to this? Have you used ipratropium bromide? Have you used any anticholinergic nebulization for a pediatric patient?
Basically, sometimes we use them.
Okay.
Yes, sometimes we use. It depends on the severity.
Yes, I'm telling it's more common with the asthmatic patients.
Yes,
If a patient
yeah.
is not responsive to any
Definitely.
other therapy, then we can use
Then we can, yeah, ipratropium.
ipratropium bromide. Yes.
Yes.
Yes, sir. Next question is about the same, but they are asking if we can use IV steroids to prevent the adverse
See,
events.
these perioperative respiratory adverse events are common with the bronchial asthmatic patients also, or the chronic bronchitis. Especially in the bronchial asthma patients, or it's a severe cold patient where we discussed that presence of wheezing could be there, or in the severity, because of the severity of the disease, then I think the methylpred in the doses oral can be used in the doses of, I think it's 2 mg per kg, or IV 1 mg per kg can be used, but that is more related to your bronchial asthma patients. When
Yeah.
nothing is, label or patient is not responding to any other thing.
It is not
Yes.
recommended to use in each and every patient. If patient
That's
is
what I'm saying. It's not.
mild and moderate URT, it is not recommended to use
Yes.
steroid in those patients.
Yes, sir. The next question they have said is, how do you fix an ETT if the tracheoesophageal fistula is at carinal bifurcation?
We can pass the ET tube till the carina, and just above the carina we fix the tube. If we pass the tube more, then we will go endobronchial. So just above the carina we can fix.
Can I add to this?
Yes, ma'am.
When your tracheoesophageal fistula is near the carina, it is difficult to ventilate both lungs properly.
Yes, ma'am.
You block that, with a Fogarty catheter, and then you ventilate. Or as he said, you have to go for one lung ventilation, then probably.
If you have bronchoscopy, then we can easily identify the site and location.
Yes.
So it will helpful. Bronchoscopy will be helpful in this patient. A site near to carina, a fistula near to carina.
Yes, sir. The next question itself says, can we use rigid bronchoscopy?
Yes, we can use rigid bronchoscopy, but it can distort anatomy sometimes. So it is advisable to use a flexible. We can use rigid one.
He's asking, can we use rigid bronchoscopy to block the fistula?
No.
Those are actually two different comments, but yeah, we can relate.
We can use to identify to locate the fistula.
Yeah. So the next question for you, sir, is, do we need lung isolation in tracheoesophageal fistula? And what mode of ventilation? Either a volume control or pressure control?
We can go for either. Volume control is preferable. But when they do thoracoscopy, one lung is collapsed, then chances of hypoxia is high. Then we have to look for intraoperative. Yeah.
Shall I read out the next one? What about the side effects of salbutamol, like arrhythmias, hypokalemia, hyperglycemia, paradoxical bronchospasm, CNS agitation? Is there risk versus benefit event for salbutamol, like in the cardiac disease, can we use?
any drugs, if you are giving in the higher quantities or for the, for the longer use, can cause all these kind of effects. The recommended dose has been, come out after the randomized control trials, and recommended dose is 0.5 ml to 1 ml, which is probably not causing these side effects. So it's safer to use these patients in a preoperative area. Okay. So this is a recommended technique, and I think we know that the benefit is more rather than the risk.
Yes. The next question is, can regional be used in severe cold posted for emergency surgery instead of pending for 2 weeks?
Now it's yes, regional. It depends on the,
Yes,
as we decided about when we discussed about the, whether surgery should be postponed or taken upon, there was a one factor which was the urgency of surgery. If your surgery can be done under regional anesthesia, and you know that the patient is a life-saving emergency, then definitely with the high-risk consent and under the, taking all precautions, doing your high-risk stratification, you have no other option to be taken up under the regional anesthesia. You can take up the case.
Yes. Thank you, ma'am. The next question is just about dexmedetomidine. Is IV dose or as nasal drops we should
Nasal
use?
dose. Nasal dose.
in pediatric patient, basically
In
infants.
pediatric patient, nasal mucosa is highly vascular, and drug gets absorbed. It's 100% bioavailability.
Yeah. And if child is more than 2-3 years old, then we can use IV. Otherwise, in small children, we can go for nasal.
Yes.
Okay, ma'am. Now the new question we have is, can we give propofol at the end to deepen the anesthesia? At the end of the surgery?
Yes, we can
That
maintain.
depends.
Yes, ma'am.
But why do we want to give propofol at the end of to deepen the anesthesia? Unless and until there is a laryngospasm, why do you want to deepen the anesthesia means? The question is not clear to me actually.
For awake extubation, they want to ask for some.
Now, if you want to go for awake, then you would not like to deepen the anesthesia. Or if you need to go for, like, there's a laryngospasm, then propofol is a recommended technique. You have to go for the propofol, small dose of propofol, so that laryngospasm can be corrected. So it depends on the situation. But if I have to extubate the patient, then I don't think I'll like to give propofol.
Yeah. I also prefer to extubate patient only when it is awake.
Yes.
Spontaneous breath is present, moving limbs, definitely. Then I used to extubate patient in this condition.
Okay. Thank you, sir. Thank you, ma'am. Those were the questions in the chat box. If anyone wants to ask the question, they can raise a hand.
Asmita, there are a few more questions are there. Have they asked that one, that lung isolation in
Yes, sir.
tracheostomy? That was asked, no?
Yes, sir.
I missed some part of the discussion actually.
No, sir. We have covered those questions. Over to you, sir.
No, I think.
There's a question. Yeah.
Speak. Carry on.
Does deeper plane of anesthesia extubation cause any problem?
Deeper plane of anesthesia extubation. Yes, you have a delayed awakening when you're there. Every technique when we are doing it is for the pediatric patients. You're awake. If you do awake patient, you see that the patient is fully awake. The reflexes are proper. But deeper plane of anesthesia is required when you don't want the bronchospasm to happen. That's my choice. I want to go for the deeper plane of anesthesia. So it won't cause any problem, but it will definitely delay the emergency. Yes, it will be beneficial for your spasm problem.
Actually, ma'am, just want to add to that. The deeper plane of anesthesia for extubation, if the airway is difficult, never try to do that.
Yes, sir.
Because again, you will be landing up in the struggling with the airway securing. If something, you may not be able to ventilate with the mask ventilation sometime in the deeper plane.
Yes,
so I think always do the deeper in plane anesthesia extubation when I think the airway was good. You were able to manipulate you were able to secure the airway in a very smooth manner. Otherwise, that can cause problem. The only problem is that you may have to spend some more time with the patient.
And studies have also shown that there is no major difference when doing the awake or deeper plane of anesthesia in pediatric patients. There are studies, they have shown this. Any more questions in there?
They have just mentioned an incident. Dr. Supreet Kaur is telling about once we tried to extubate the child in deeper plane after spontaneous breathing, and the child had decreased saturation.
Yes, there may be asynchronia if patient is not properly extubated. Maybe the efforts were not proper, and they put the patient on the spontaneous breathing. So tidal volume could be less. There could be many factors which could result into the decreased SpO2. So it's not a good taking that sir has mentioned. We drew it away.
Your voice.
One thing more, when you are extubating a child in deeper plane, it is advisable to put a nasopharyngeal airway. So it can prevent obstruction.
I think that exactly the deeper plane is when you extubate the patient, there should not be any, that the stress response of extubation.
Yes.
If the stress response is there, that means the plane was never deeper, and you will definitely may go for this laryngospasm or bronchospasm, something. That complication can happen if the plane is somewhere between the deeper and fully awake. So you have to be very careful for that. These type of things happening there. Either you are having a base or you are monitoring this what you call depth of anesthesia in those patients. That is very important when you are extubating these patients in a deeper plane. If you are anticipating a complication, and if the URI, I think these complications will stand a much higher chance to develop if the plane is slightly deeper or if plane is less deeper, or you want to go for a week. These will definitely be there. So individual approach according to the patient, according to the clinical profile of that patient on that case.
Yes, thank you, sir. We have Dr. Shobha Vatkar. She wants to ask a question.
Good evening, sir. A very good discussion. I just want to know the patient with the URTI most often after extubation there is a longer breath holding. Like the breath holding is so long that sometimes the patient may desaturate. In that case, what I have used is a given 1 cc, that is 10 mg propofol relieves the spasm as well as the patient is deepened. So the spontaneous ventilation reoccurs. That's what I have practiced. So at the end, I give 10 mg of propofol to relieve that spasm as well as the patient is in that deep plane of anesthesia where the spasm can be prevented. That's what I have practiced in this.
That's what ma'am sir has told. There's increased risk of laryngospasm if patient is not in the deeper plane of anesthesia and you are trying to extubate the patient. So propofol here is a solution for that. You give a 10 mg propofol, patient will be better.
Yeah, that's what I feel that's a better mode of extubation.
Yes.
And there are many more drugs are also available. I think it all depends upon your comfort.
Relaxant also, yes, sir.
You can go for that lignocaine also. This Zalocard with that preservative-free lignocaine. That is also very helpful. So there are many choices of drugs. I think it depends upon your institutional practice and your personal experience with those drugs. There are so many things in the textbook, so many things in the practice we have learned over the years. So I think with the time, Dr. Shobha Bhatkar, madam, she will be able to extubate much, smoother than the younger Asmita can do. So not to hurt Asmita, but
Many times just holding the jaw, like a jaw thrust, of course, many times relieves that breath holding and the child tries to breathe. That is one breath itself, it is a smooth ventilation afterwards. That's what I'm.
Yeah,
Jaw holding, jaw thrust.
Over the years, ma'am, you learn so many things you can all put into practice whenever these complications are happening, rather than you don't go the algorithm in a panicky way. You can choose the algorithm in a very smooth manner. This is the thing, so we will do this thing.
So sometimes we don't have propofol. We have to use an inhalational to deepen the plane. So whatever we feel feasible, we have to do at that time.
Yeah, and because over the years you develop an art. art of
Yes,
giving
sir.
and administering anesthesia. I think that any first year, after the end of the first year PG, they will think that we have learned everything. Now the real learning comes after completion of your SR-ship if you are doing an institution. After 3 years, then you really learn the things. People going to the practice after anesthesia, that's something that things are not required in that proper way, because senior residency under when you are grinded to such a exhaustive schedule and the clinical complications, you learn many things which will help you in practice also, will learn in academics also.
Yes, sir. Thank you, sir. There's a new question. Is propofol recommended below 1 year, and what is the current recommendation?
Same, what is your take on this?
Ma'am,
We are
basically,
using propofol in every case
I,
below 1 year also,
I
and it's
use
now recommended.
what FDA has approved up to.
Yes.
We can use propofol more than 2 years of age, but we are using in every cases propofol right now. We are using in every cases, and for so many years, and we have not seen any adverse effect on neonate or infants after giving propofol. So
Bajwa
what
sir, what is your take on
approved?
this? Because we are using it in every
Yes,
case,
ma'am. Same.
almost.
We are also using propofol in same case, in every case.
Actually,
Sometimes we avoid in neonate, but in infants, in more than 2 or 3 months, we are using propofol.
see, the drug, the mechanism is same, whether in the pediatric or into the adults.
Yes, sir.
The FDA approval
Yes,
is
sir.
for drug when they are giving, approval after policy making.
Mm-hmm.
Now, I'm just giving an example of dexmedetomidine.
Yes,
How
sir.
much approval you have got? You are using it everywhere in the body, in the
Yes, sir.
blocks, in the epidural, in the spinal, in the IV, in the inhalational people are using. So many things are there. So FDA doesn't give approval for every drug for every route also.
Mm-hmm.
Now the propofol drug, it has safety has been established over the globe now.
Yes,
Whether
sir.
you use in infant or you use in the what you call adults. Off-label use,
Mm-hmm.
everybody is using, I think, in neonates also. Off-label, if you are asking me. But have anybody reported a complication till date? There is no way mechanism that has contraindicated in the infants or the neonates also by the FDA. With the policy, if you read the policy documents of the approval, you will
Yes, sir.
come to know, because these are the the protective policy making decision by the administrators in the especially in the ASA.
Mm-hmm.
So whatever they design it for the preventing the complication and patient safety factors. But I think when you do the studies, when you come across the anecdotal case reports and something like that, only then you will be able to see with the certainty, you will be able to say that this drug is not good for that age group.
Mm-hmm.
I think in the initial studies, I think that policy document is continuing. In the initial studies, what they did when propofol was, given for approval in the this one ASA meetings at that time, many contraindications were there. I think all the contraindications have eliminated to and become obsolete over the years. Now this drug is being so safely used almost in every age group. But a neonate and that infant, they just because it has not been recommended by FDA, that's you cannot use it safely. But there is no sometime just imagine for a neonate coming to you, you may not be having ketamine with you. Suppose in any difficult airway or something like that, you have a propofol only with you. Thiopentone is not used nowadays. So
Definitely.
etomidate or propofol or ketamine, what drugs you have got with you?
Mm-hmm.
These are the only drugs which you have, and they are
Even
safely
sevoflurane is not
established.
available at all places, sir.
Yes.
Which one?
Even
Sevoflurane.
sevoflurane is not available at all places for induction.
Something is happening on the screen. I'm just wondering what is that.
Huh?
Now, you were saying something I didn't listen, Brad.
I just said that sevoflurane is also not available at all places, sir.
Ma'am, sevoflurane is not available at more than 70% of
70%
the
of the places,
hospitals
yes.
in India.
Uh-huh.
Yes.
Whether you go for the multi-specialty hospitals or the small nursing homes or wherever, sevoflurane you will not get everywhere. So I think many places still the halothane is going on, although it has been stopped by the company now for the
Yes,
manufacturing.
sir. Yes.
But I think even desflurane is not available. Sevoflurane is not available. ISO is commonly available than sevoflurane.
Yes, sir.
That only you can
Yes,
say
yes,
nowadays.
yes, I see that.
Any more questions?
So previously we used to have only halothane for the pediatric cases, and the only drawback was that spasm. Halothane has got the intense execution spasm. That was the initial query. So initial problems we faced with halothane.
Halothane spasm, we have not heard that much because the desflurane is the one which causes more spasm. Halothane, only the thing is that the dosage of the halothane safety factors as compared to sevoflurane. That's why it has become obsolete. But I think the majority of the times it's because the plane of the depth of the plane of anesthesia when we are doing the intubation or something like that. That can be the reasons in many cases when we are using halothane. And the methods have improved over the time. When we started our career in post-graduation in anesthesiology, what the methodology was there in teaching, it has evolved over a time now. The more safety procedures, safety mechanisms have come into place now. I think many people will agree with me who are having the post-graduation of more than 25 years now. They will be agreeing that things have changed over a lot.
More bradyarrhythmias were common in the halothane rather than the spasm. But now, as you said, lot of
Yeah,
learning
CO has
we are
solved
also
every
learning.
problem. Yeah. CO has solved right from pediatric to geriatric. CO has solved a lot of problems. But initially, I started in the era of ether in 1982 onwards. That time, that was the only agent. Then came the trilene. Then
Yes,
all this
Ma'am, we have
halothane.
also used halothane a lot in our residency period. But with time now, everything has improved. So
Thank you, ma'am.
thank you.
Dr. Madhuri, your comments? Summarize.
To summarize, I think URTI in pediatric cases is a big dilemma even today. This is what I feel, and we need to frame guidelines for that. And at least from, and the second point is the tracheoesophageal fistula is challenging as usual, and no amount of discussion is going to relieve our suffering if a problem occurs during the case.
No, but what the latest treatment pattern in a tracheal fistula is with the neonatal surgeons also coming into play, pediatric surgeons, they themselves are managing the post-operative, focus and areas in the respective NICUs and PICUs. So in all those areas where a pediatric surgeon is helping, I think the teamwork has established a good survival rate in these patients, less of the complications post-operatively. Because previously, if the only anesthesiologists, many places still anesthesiologists are managing these patients in the post-operative ward or this one NICUs. But now I think in over many places where this one MCH is there, pediatric surgery and some neonatal surgeries have also come up. It has made the procedures very safe and the results are good. The teamwork has improved over those years now. Over the last 10 to 15 years, the things have improved a lot in these things. But I don't know, practice vary from place to place, whether the pediatric surgeons are compliant with you or not.
No, I agree fully with you, sir. One more point is the pain relief after surgery of tracheoesophageal fistula. That is very, very important. In most of the places, the pain relief post-operative is not given well, and the babies die of respiratory complications. So
That's also true. I think
is one
post-op
thing which is
analgesia in
taken
any
care of.
surgery, especially the cardiothoracic surgeries, the airway surgeries, the pain is because these are highly sensitive areas with your glossopharyngeal and vagus coming from there, and the pain receptors are maximally focused on these type of areas. When you have a stress response, just imagine how much of the load, almost 1/3 of the load of nervous system is in these areas where you get a stress response. So I think to suppress the pain in these type of surgery is very, very important. Before we say something, we have to felicitate our faculty also. Is my screen visible?
Yes,
Yes.
Yeah. So, Mamta ma'am, thank you very much
Thank
for
you,
today's.
sir. But sincere apologies for the technical. Though I was sitting next to the internet, I don't know what was happening. That my voice was totally breaking up.
It happens to me also many times, ma'am. It's not your problem, it's a problem with the network.
Maybe it was my first time. Next time would be more cautious. Thank you, sir.
Yeah, sure. Thank you, ma'am, for being the leader of this team and preparing the PDs well. And Similarly, Dr. Prem Raj, he has been, one of the very dynamic educator in that part of the country. He very continuously keeps on education programs. Every 3 monthly, I think get a message from him about some educational program being done there. And
He's very active in academics in Lucknow.
last March only they had a PG assembly also.
Yes.
They had a 3 days PG assembly, in 3 or 4 days PG assembly, I think.
4 days, 4 days.
4 days PG assembly they had in Lucknow. Thank you very much, Dr. Prem, for
Thank you,
being
sir.
such a good educator.
Thank
And
you.
Amita and Shreya. So you both were good. Just actually you were able to answer, but I think you were prevented by Dr. Mamta Madam very nicely today. Some few questions were also there which Madam asked on your answered on your behalf. And thank you very much for being a good presenters today. And Asmita, it's your debut as a screen coordinator. So you will be associated with us for a long time now. So thank you very much.
Sir.
And
It was my pleasure.
thanks to your mother also for introducing you to the class, online
Thank
class,
you.
PT classes.
Thank you, sir.
And my thanks to Dr. Madhuri, Dr. Nishant, and Dr. Pritima because they are the initial people who have maintained all the decorum of these classes. That's how these are going every day, every Monday. Sometime on a Tuesday when the Monday is some festival, so we do it on Tuesday. So before winding up, I think another 2-3 minutes, somebody wants to ask something. We can answer and then we can log off.
Bajwa sir, I want to say something.
थोड़ा सा लाउड बोलना अभी आपकी आवाज माइक के पास आ जाओ.
Thank you, sir, for giving us the opportunity. Sir, you leading the ISA very nicely, sir. We are seeing every week you are doing all the academic activities. So I think ISA is flourishing very high under you, sir.
Thank you, Dr. Prem.
You are doing great job, sir.
This needs a constant motivation to continue with these classes.
You all people are my
These
motivation.
Nice. No, sir, it's really very inspiring to see doing you this, really inspiring.
Yes, sir.
Thank you, ma'am. Thank you very much. And we hope to, Bacho, Shreya, and this one, Amita. You do the registration, present your papers under the guidance of Dr. Mamta and Dr. Prem at Patna ISACON. Okay, do the registration there. You are final year student. When is your exam?
So this January date is there.
So I think they can present the papers there also. Still we have too much of time. So in the November, the presentation will be there. So it will be good. Whichever PGs are presenting on this online forum. I think the requirement is also of the NMC side also there.
Yes, sir.
Yes, sir.
So I think presentation at the national, it will give a more of confidence to you people. So get registered and prepare for presentation there. And Dr. Mamta Madam and Dr. Prem,
Yes, sir.
get a maximum participation for the conference. That is my request to you all.
Thank you, sir. Thank you.
Thank you.
Sure, sir.
Okay then. Good night,
Thank you,
everyone.
sir.
And we always end by saying.
Thank you, Dr. Madhuri. Thank you, Dr. Smita.
Thank you.
Thank you, ma'am. Thank you, sir. It was